Good evening and welcome. I am Dr. Digveer Jayas, Vice President Research and International at the University of Manitoba. I would like to begin by acknowledging that the University of Manitoba is on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. These cafes have been an initiative of my office since 2008. In that time, we have held more than 65 of these discussions, all in person. 2020 and the global pandemic has changed the format, but I hope not the engagement. I am happy and excited to be able to continue these events in a new format that reaches a wider audience from the comfort of your home, wherever that may be located, to learn firsthand about what our research experts are doing to find solutions to local and global problems. Tonight's panel of experts and moderator will share their expertise on the current state of long-term care facility design and how we can effect change for the betterment of the residents in these facilities and their quality of life. I encourage you to participate in the conversation with our experts. I will hand things off to your moderator for this evening, Dr. Michelle Porter. She is a director of the University of Manitoba Center on Aging, as well as a professor in the Faculty of Kinesiology and Recreation Management. She will tell you more about tonight's experts and how things will work in this format. Megwich, thank you. Merci.
Thank you, Dr. Jayas, for your introduction. And I'd like to thank everyone behind the scenes who've made tonight's event possible. I would also like to thank Kelsey Grabowski, who's an interior designer and former master's student of Dr. Shauna Mallory Hills at the Faculty of Architecture. She allowed us to use one of her design images in the promotional materials and the lead slide for this cafe. The image was part of her thesis research titled Redefining Residence, an alternative memory care environment for single childless persons with Alzheimer's disease. Before I introduce our panelists, I want to say a few words about the reasons for tonight's event. Back in the spring, when we proposed this topic, it was very clear that action is needed regarding long-term care. Globally and nationally, the pandemic has highlighted the long-known issues surrounding how residential care is provided to older people. The many underlying issues have led to the very high mortality rates seen in countries around the world, with Canada having one of the highest mortality rates, with about 80% of deaths occurring in residents of long-term care facilities. Our thoughts go out to the residents, their families, and people working in long-term care during these troubling times. As conversations are occurring about the increasing number of long-term care spaces due to population aging and improving living conditions for those needing long-term care in the future, it is important that we consider the many modifications that are necessary to prevent infectious disease spread of any kind, whether it be respiratory or otherwise, as well as improving the quality of life of residents. One major consideration that does not receive very much attention is the built environment. The buildings associated with long-term care can have profound impacts on a whole host of other factors that ultimately affect the residents, most of whom are older people. On this, the 30th anniversary of the International Day of Older Persons and the launch of the Decade of Healthy Aging, it is important for us to engage as a community to provide directions for the future of improving long-term care in Manitoba and globally, and ensuring the dignity, human rights, health, and quality of life of older people. And that's the reason for this discussion tonight. So throughout this evening, I will be your moderator for this discussion. And so I'm going to give you a bit of an overview now of how we're going to proceed with this online cafe. So each of the three panelists will speak briefly and they'll share their perspectives on the topic. Then I will open things up for questions. For this online format, questions will be posed via Slido. And there's a link in the YouTube description in this feed that you're watching, and it'll also be on the screen throughout the discussion. You don't have to use any software or have an account. You just need to have an internet browser and the discussion code, and you can start entering your questions anytime you want. And I'll be moderating those questions from Slido when the panelists have finished their brief comments, and I'll be posing them to each of the speakers. So that brings me to tonight's panel of experts, who are all alumni of the University of Manitoba. They are Dr. Malcolm Doupe, Mr. Rady Friesen, and Dr. Shauna Mallory-Hill. Dr. Malcolm Doupe is an associate professor of community health sciences at the Manitoba Centre for Health Policy, Max Rady College of Medicine. He is also a research affiliate at the Centre on Aging. He conducts research in the area of health services utilization and the aging population, investigating risk factors of home care and nursing home use, factors that influence quality care, and changes in functional status in nursing homes, and issues related to care continuity for older adults. Mr. Rady Friesen is an alumnus of the University of Manitoba, graduating in 1965 with the Bachelor of Architecture. Now he is a retired architect with more than 40 years of experience in forward-thinking and creative designs for the aging population, including the first household facility based on the Chez Nous concept, completed more than 20 years ago. And this was the Fisher PCH in Fisher Branch, Manitoba. This is an early example of the household model. It opened in 1999. He is a partner emeritus at FT3 Architecture, Landscape, Interior Design, the firm he founded here in Winnipeg in 1975. He researches best practices around the world and advocates for better care and housing for older adults. His experience also includes serving on a national age-friendly housing task force and on local boards of care facilities. He's a member of the Society for the Advancement of Gerontological Environments and the Canadian Association on Gerontology. Dr. Shauna Mallory-Hill is an associate professor of interior design at the Faculty of Architecture at the University of Manitoba. She is also a research affiliate of the Centre on Aging. An environment behavior researcher, her research explores the impact of built environments on human productivity, health, and well-being. Her current research concerning older adults relates to aging in place and design for persons living with dementia. So now I'm going to call on Dr. Doupe to make his remarks.
Thank you, Michelle, and welcome everyone. So as Michelle mentioned, my role is to provide a little background information and help to set the stage for my peers to talk. So I have listed 2 reports that you should be seeing that at least some of my comments come from. And the first report is from the Manitoba Centre, thank you, the Manitoba Centre for Health Policy at the University of Manitoba. And that discusses personal care home use patterns, projections of personal care homes, what supportive housing is, and the extent that it has impacted use patterns in Manitoba. The second report is just released by the Royal Society of Canada, and this provides an excellent picture of PCH or nursing home care across the world, how we as Canadians are doing to other countries, why COVID has had such a dramatic impact on PCH residents, and as Michelle has mentioned, why some of these baseline conditions, or given them, it's not a surprise that COVID has impacted nursing homes to the extent that it has. So I have 2 or 3 points I want to make just as to get us started with this and to provide some background. And the first is that personal care homes in Manitoba provide about 3.6 million days of care annually to our oldest old and our most vulnerable, I call foremothers and fathers, the people who have got our society here today. About 1/12 of our healthcare operating budget goes to providing this care. Most personal care home residents in Manitoba are 75 plus years of age. In any given year, about 1/3 of all of our population of 85 plus year olds live in a personal care home, and this is their home. And that message, I think, that this is their home is a very, very important one tonight. So I'm going to spend a few minutes talking about before COVID, pre-COVID. And the first thing I want to say is that, you know, the current and projected strain on home care, what I'm calling supportive housing, nursing homes, the care continuum is incredible, and it's just getting started. Older adults are the fastest growing segment of our population in all developed countries. Most evidence, however, suggests that added years of life for a lot of people are not necessarily spent in good health, but are accompanied in many instances by chronic diseases and disabilities. And so almost all jurisdictions in developed countries have reshaped their older adult care continuum, and there are three consequences, or major consequences of that I think exist. The first of these is not really related to today's topic, but I think it's important to point out that people are now living in the community with many more health-related needs compared to the past. And it's not the focus of tonight's talk, but I think it's very important to ensure that we have the right community-based supports to care for people before they get in to a personal care home. So that is the first consequence of this. The second consequence of this is because people are staying in a community for a longer period of time, going into a nursing home much later in their life, the clinical profile, I'm going to say, of personal care home residents has increased dramatically. And so, you know, providers have a very challenging task to balance providing very, very good medical care, but at the same time, this is also the person's home. So balancing that with choice, flexibility, psychosocial care, those types of things. We are in a situation where we have to make some changes to our healthcare system. If we keep providing care the way that we do, we're projected to require in Manitoba anywhere between 50 and 85% more PCH beds by 2030. That's a large number in a very short period of time. We also have to keep in mind, however, that upwards of 1 in 10 people that come into a personal care home have lower care needs. And if we start to make comparisons across jurisdictions, those people would not necessarily get into a personal care home elsewhere. So yes, we actually did some research on these lower care people and asked them, well, why were you admitted into a PCH? And most of them say it's because of exhaustion. That's a huge burden of care for informal caregivers while you're waiting to get into a PCH. And people talk a lot about the lack of community supports while they're waiting to get in and the repeated acute care burdens. So there's a lot of work to do, I guess is my point, before we get into the PCH sector. My third point relates to tonight's conversation. I mentioned before that individuals that are heading into a personal care home are much sicker than in the past. 50% have a significant form of dementia. Upwards of 80% have at least some type of dementia. Almost every other person requires weight-bearing help to complete an activities of daily tasks like dressing and feeding, those types of things. And so this brings to topic, and every aspect of the healthcare system is dealing with this question, I think, is, well, given everything I've said, do we need more resources in this sector, or do we need to do things differently? And I think the answer is, yes to both of those. The first is from a more point of view, public operating costs, so excluding capital costs and what people pay for per diems. We put out about $180,000 per PCH bed per year for facilities. Planners in every region I know are grappling with this whole issue of, is that enough? But there are lots of opportunities to do some things differently, and this is where I think this leads into tonight's conversation. The first of these is talking about care approaches. I have seen facilities, and I'm talking facility layout now. I've seen facilities not in Manitoba that have 4-6 residents per room, the same wake up time for everyone, irrespective of how well someone slept that night. I have seen facilities that actually have a rule that everyone goes in a wheelchair when they show up to reduce their risk of falling. I've seen meal times in auditorium-like rooms with tables helter-skelter a little bit, and people wheeled up for a place to eat at random. And this is the type of environment that sets the perfect storm for a pandemic like COVID. I have also seen, however, the opposite of that, and including homes here where people live in small pods, so sections of a room. I believe that Rudy's going to show you some examples of that. That gives people the flexibility to wake up when they want, that gives them to eat a meal not at a regimented time, to actually dine with a smaller group of people, that give residents the ability in some way to help make their own meals, those types of things. So we have a huge diversity in the facility profiles, the PCH facility profiles that we have, not just locally, but everywhere across Canada. This is a great time to have this conversation like tonight. If we are going to be talking about building more of these facilities, a logical question is, what should they look like? So I'm going to stop there and turn it over to my colleagues, and I'd be happy to answer questions later.
Okay, well, thank you, Malcolm. That was a fascinating explanation of the current situation, especially what you described for Manitoba, where, yes, there are still facilities that are pretty awful, but there are also facilities that are showing the better way, the new way. So because I sometimes digress from what I'm talking about or take off on a tangent, I've prepared a number of notes here, and we'll refer to them continuously. Hopefully they'll keep me on track. I'm not going to talk a lot about the existing care home product, if you will, in Manitoba. But I'll just mention two things at the outset, two comments about older adults. One is that it says, one of the things that older adults fear most is ending up in a nursing home. And you hear that a lot. Another one is, according to surveys, and a number of surveys have indicated this, more than 30% of our older adults would rather die than end up in a nursing home. So this is really quite horrendous, and it's why we need to change the design of long-term care facilities to small-scale living environments. So why is a small-scale living environment better? Well, it's about power of normal and about power of security. Research shows that residents experience higher emotional well-being in this other model, and they have both well-being, pleasure, and social interaction with each other and with the staff. And they have better cognitive and functional abilities. They're less agitated, depressed, and given fewer drugs, or needing fewer drugs, if any at all. And now COVID has shown us another big advantage. With much smaller cohorts and fewer and consistent staff, there's a significant reduction in virus spread in these smaller facilities. From my research to date, the household model is, I think, the best option to go forward with, at least at this point in time. What are the distinguishing features of the household model? I'm going to refer to the Greenhouse project a fair bit. It's the most well-known household model. It's been around for almost 20 years, and there are at least 300 locations. A greenhouse looks and feels like a home. Multi-skilled staff stay with each household and get to know the residents really well. They do all the cooking, light housekeeping, laundry, bathing, and organizing of activities for the residents. There are no long corridors with shiny floors and glaring fluorescent lighting. There are no nurses' stations, and there's no hospital food. So when designing, the first consideration when looking at details and so on is, would you have this in your home? The second consideration is, would this environment be familiar to people with dementia? It's very important for people with dementia to be able to be in a place where they recognize things, the things that they're familiar with. So let's have a look at a typical household floor plan. If I could have the first slide, please. So what you see here is a fairly simple, straightforward layout. There are 10 resident rooms, partially surrounding the what's often referred to as the hearth area. It's the kitchen, dining, living area. And you also see on the outside the adjacent outdoor patio, which is also very important because connecting with the outdoors is really a very important part of this household model. A few other design considerations that I would like to touch on is the first one is the front door. In the household model, the emphasis on the front door is significant. That's because the front door helps residents retain their identity when they move into a facility. It's a sense of entry. It seems a sense of entry is very important. If I could have the next slide, please. Probably the most important design consideration, and I'm not going to do a lot of talk about a lot of design issues today, or at least not at this point. The most important design issue, I think, is the consideration of scale, the scale of the building, the scale of the house, because it needs to feel like a house. And so if you could go to the next slide. In terms of the design, the success of developing the scale depends on two things, basically. The size of the household, that is the number of residents in that household, and the skill of the designer. And the easier it is to achieve that scale, or the lower the number of residents, the easier it is to achieve. That scale is achieved. And the photo you see, the photo you see on the screen, it's a fairly typical interior for a 10-resident household. You can see a lot of residential elements to it, but I would suggest that the scale is somewhat grand. It's really not quite what most of us would consider to be similar to our homes. It might be similar to some of your homes, but certainly not to mine. But there are some good things about it. You see the dining room table in the background, and some say that the number of residents being set at 10 is based on the fact that you can still get 10 people around one long dining room table. I'm not sure how true that is, but it's something that's important, that people be able to share their meals together. So that, in my opinion, the ideal is somewhere between 6 and 10. And if I could have the next slide, please. This is the interior of a household model in the Netherlands, a place called De Hogeweg. It's become quite famous. And here there are only 6 residents per household, and the interior looks to me very much like a typical home interior. And the residents there, you can see they're spending time together. So the De Hogeweg, by the way, has 23 of these households in one facility. So I want to stress the point that these households are not, or don't have to be singular or independent, individual 6 or 10 resident homes, you can have many of these households within a project, within a building. And so you now have multi-household facilities that in projects that are where they're connected by shared community spaces. They can start creating neighborhoods. You have households in multi-story buildings where you have maybe two resident or 2 households per floor. You have households that are connected to other levels of care, to multi-generational and mixed-use developments as well. And an example in Rochester, New York, has 2 households incorporated into a suburban townhouse development. So who is the household model suitable for? Well, I would say it's for anyone who needs 24/7 care, both for cognitive and or physical health issues. It's basically those people who are in long-term care now, except maybe that 1 in 10 that Malcolm mentioned that may not need to be there. And I think that's true, what he says. It's also important to note that, and I'm saying that there's 70 to 85% of the residents in long-term care have dementia. Malcolm mentioned 80%. I hear different numbers, but it's not the point. A large percentage of people in these households or in any long-term care situation have dementia. And in the household model, there's the tendency to not segregate people with dementia, not to put them in separate memory wings or memory care. The tendency is to keep them with the other residents to avoid the stigma that is often associated with having someone in a memory care facility. So in terms of timing, if not now, when then? Well, I think this change is long overdue. More than 20 years ago, the Chez Nous concept, Michelle mentioned it in the introduction, the Chez Nous concept was born actually in southern Manitoba. And it was really a household model in every respect. The first example was the project in Fisher Branch that I was involved in and my firm was involved in. It opened in 1999. The residents, staff, and the community were really very happy with it. And there was a huge drop in use of suppressants in that facility. I should also say that they're still very happy with it. But that concept didn't catch on. There was no support for it. The good news now is that in Manitoba, the household model is back. And if I could have the next slide, please. Pilot household projects are already under construction in Steinbach and Carman. And they're being built at almost half the cost of the institutional model that's been built until now. And this is partially due to changes in the building code interpretation. And now that COVID has so quickly exposed the cracks in our long-term care system, it's high time to revolutionize the way we design for long-term care. So in conclusion, I would say that small-scale living has the potential to make long-term care humane, life-giving, affordable, and safe. A place where you might like to live. Thank you. I'll pass it on to Shauna now.
Thank you, Rudy. Thank you, audience, for joining us tonight and taking part in this cafe and discussion. As the researcher on the panel, I'm here. I knew Rudy was going to talk about some solutions, but I also wanted to talk about a little bit about process and a little bit about maybe be a bit provocative. So the first question as a researcher, as an environmental design researcher, I look at the question, does design actually matter to the physical health and mental well-being of older adults? And, living in these long-term care homes, and how do we really know that? So the first question, does design really matter? So I'm going to ask for the first slide. just my first provocative slide. So for those of you who have been following the news, we have recently developed, or the province of Manitoba has tendered $17.9 million to develop visitation shelters. And these are 90 have been commissioned to be constructed by the PCL company. These are to be backed up to the long-term care homes, and then on the other end is another door where up to 5 visitors can enter. So on the left is the visitation shelter that has been designed for people to come and visit their loved ones. On the right is a design by Public City Design Architecture by Peter Sampson, done in 2013. It is similarly 3 CCAN containers, $350K or $116,000 each. It's a washroom. So if you are looking at these designs and we're saying, which one would I want to bring my older adult to, which one would you prefer? So when we think of designing for older adults, there is a social justice piece. It speaks to how much a society cares, how much the rights of the people matter, and it also talks about what people value and how much design matters. I just wanted to show you the interior of this visitation shelter and talk a little bit, second slide please, and talk a little bit about how much design matters. And then a person in a wheelchair perhaps sitting here can't see out the window. Is this an environment that is humane and that speaks to you of family visits and comfort? Not to me, but I think it is an issue that we need to think about the value of design in creating environments that are humane for adults. So the social justice piece, thank you, Luke. The social justice piece I want to talk about is that in terms of process, there should be no design without older adults involved. Participatory design, stakeholder input, and involving the people that have to use these facilities is really critical. And I think that voice has not been in the process very much. As a person who does a lot of research, and myself was, my mother had dementia. As a person who does a lot of research around designing environments for people with dementia, sometimes their voices are not heard. But it's really important we lean in hard to listen and understand the needs of people living in these environments. The second point I wanted to make is, how do we know if design matters? My whole world is around needing to learn from existing buildings and the people that occupy them. There's been 7,000 plus COVID-19 related deaths in Ontario and Quebec, reported as of September 16 in long-term care facilities. We saw immediately that that was a consequence of not having private rooms, that they were put in large cohorts, that inadequate HVAC systems. These are very functional kinds of requirements. There's currently 127 licensed nursing homes in Manitoba. Some have had outbreaks, some have had deaths. Is there something we can do? So what's next? Gerontological designers, researchers like myself, we already know a lot about designing for wellness and quality of life for older adults living in long-term care. And it's based on studying existing facilities. But we need to do a better job of translating that into practice. I think the way is, not necessarily to make designers in practice into researchers, but that we need to team up with academic and industry partnerships to get the information out to practice. The third point I wanted to make is, what is it we should be studying? And this is something that I've just sadly just come to the realization in my later years of researching. We spend a lot of time researching the performance of building around function, HVAC, indoor air quality, accessibility, viral safety, support, safety in terms of falls and so forth. And we look at psychosocial issues like relationships and family and the ability to accommodate partners, personalization of space, choice and autonomy. But there's a third factor that we seem to have forgotten about, and that's growth. When older adults don't stop evolving, they need to maintain and develop new skills and knowledge. They need to have artistic endeavor. They have to have fulfillment. They need to be able to help others. They need music. They need delight. They need beauty. The idea of intellectual support is often overlooked. And when I showed you the container versus container, could you see what the difference design makes? Back to you, Michelle.
Okay, so now it's time to go to audience questions. If you haven't done so already, please go to slido.com and enter in the code D377, and you too can add your questions to the list that has started. And so I'll now be reading them out for the panelists to answer them, and we can have multiple people answering questions or one person. We'll see how we go. And just before I start the questions, I do want to remind people that this will be available for viewing later. So we will have this on the website at the university for the cafe, and I'll give you that address later. And we also will have some of those resources listed on that same website, so you'll be able to check those out. Okay, so I'm going to go to the first question then. Malcolm, this might be one for you.
Okay.
Do we know the percentage of nursing homes in Manitoba that have the dated model of regimented meal and bed times that you mentioned?
I would say the vast majority of them. The Long-Term Care Association of Manitoba in CBC, or the Free Press meeting it was the other day, came out with a statement of a 2015 report that was done, and I think this was just in Winnipeg nursing homes, and I think that it says that 50 to 60% of the facilities are in poor condition and require updating. I would say the majority of the facilities are more of the opposite of what Rudy was talking about. And that's not, I want to emphasize, it's not because providers don't care or they're not trying or they, put in less effort or anything like that. It's the, you're limited a little bit once the facility is built in terms of how creative you can be. So I would say it's the vast majority, Michelle.
Okay, and I'll go back in the question. It was also around the model of meal times and bedtimes, which is a little bit disconnected from the infrastructure itself, although sometimes it is also connected.
Yeah, I'm not going to give a number for that. I don't know the answer to that. I will give it with a story. And again, this is not in Manitoba. I've been very fortunate. I've been through research projects sent across Canada and lots of different countries, and looking at approaches to care in nursing homes. And I've seen things that are, how do I get into this place? I've also seen things that make me want to put my head down on my hands and cry. I witnessed a woman one morning. I was sitting there at 7 o'clock in the morning in their auditorium. They wheeled her in. They sat her in front of a wheelchair or in front of a table. She sat there for 45 minutes before anyone else came into the room. She didn't get water, coffee, or anything. They were getting people in for mealtime. Part of that is because of the way the facility is set up, that everything is happening en masse. Chunking it into pieces like Rudy is talking about, I think makes that much easier to do.
Okay, thanks. Anyone else want to chime in on this question, or should I move to the next question?
Well, just very, very quickly, if I may. I think the traditional, what I would call the medical model of care home that does work with fixed schedules and so on. Often those schedules have been set for the benefit of the staff, and that's not a knock on the staff. But it makes it very difficult for the residents. The administration is trying to make the work of the staff more efficient, or the time that the staff spends more efficient. So it's the tail wagging the dog.
Okay, I'll move to the next question from Haley, and her question's around double rooms and couples. So I feel like double rooms for couples are not very common, but I feel like this would be very beneficial. Why is it that there aren't very many, if there aren't, and what are the barriers?
I'll respond to that. First of all, I think Manitoba is very fortunate in having, like, the time that I practiced in Manitoba, not once did I have to get involved in designing a facility with anything other than private rooms. So private rooms have been the standard as long as I've been involved there. But the question does come up: what do you do for couples? And rather than have double rooms in case there might be couples, what we did in the Fisher project was we put doors between two typical resident rooms, like you do like sometimes you do in a hotel, or you have in a hotel. And when the couple moved in, they got to have the equivalent, or actually have two rooms, and they could either sleep together in one room and have the other as a small sitting area, or they could each have their own room to sleep in, but still be connected without having to go out into the corridor or outside the rooms. So I think that's a better way of dealing with, but certainly it's good to have the possibility for couples to live together. Absolutely.
I guess I'll chime in. I think in terms of individuals living with dementia, often the long-term care facilities are divided by populations. So folks with dementia are put together in a ward, and that makes it very difficult to have other folks incorporated into that population. At least that's what I've seen in other countries like Hochbike. They had similar what Rudy's talking about, where we have couples living together on a campus of sorts. It is interesting to me to say that the support of the partner or the significant other in the wards I've been on is really significant. Often the partner will come on a daily basis to visit their loved one, and of course in a time of COVID, how do we address that now? How do we facilitate that now? And in some instances, it's very difficult.
Malcolm, do you want to weigh in on this one at all?
No, it's okay. I think enough's been said. Yeah, thanks.
Okay.
I could just follow up on the family visiting. More and more people are saying now that we should really give more thought to, especially where families have been part of a residence support system, if you will, that we should allow those families to come in. Not necessarily always, but we need to be a little more flexible about bringing families into the resident, into the homes to spend time with their family living there, because loneliness can also hurt people and kill people.
Yes. Okay. We've got a couple of comments about loving the idea of supporting growth in long-term care, and loving intellectual support and development point. Next question is about how do you recommend adapting the infrastructure of older PCH homes? Shauna, do you maybe want to chime in on this one?
Well, yeah, it's a challenge because we're dealing with a lot of infrastructure that's already there, and of course residents who are already in long-term care homes that we want to make their worlds better. And of course, we have limitations of existing structures. So, for example, trying to go from an institutional model to a small household model is really tough within an existing, framework of walls and doors and so forth. I think that some of the approaches of changing the care model might impact a lot of this, and how care is delivered, and providing that flexibility, providing different kinds of leisure options, that maybe the way things are delivered might address some of those issues that we see, that maybe not with bricks and mortar we can change, but perhaps the quality of life can be changed without the major substantial changes to the infrastructure. That said, a lot of these facilities are long in the tooth, and it's surprising how much just a fresh coat of paint and some updated finishes can go a long way. Some new furniture can go a long way to making a difference and to making environments more home-like and less institutional. There's a lot more options now for furnishings and finishes that don't look so hospital-like, if so to speak. I think the idea of personalization is also really critical, so that people have the opportunity to make their environments more home. Those are some of the ideas that I can see, but it is challenging for sure to try to insert a different paradigm into an existing infrastructure. Yeah.
I can follow up on that. If the people running the greenhouse project actually currently are running a series of workshops, online workshops. I just participated in one yesterday, and what they're doing is they're looking at how the principles of the sort of the key principles of the household model can be applied to existing facilities like that are based on the medical institutional model. The question then always is, can they really achieve something? And the answer always is maybe. But the attitude that they have is that, if you can get three factors out of 4 into a facility, that's better than not changing anything. And so they have provided a number of examples of fairly large institutional facilities that have been, cohorted into smaller groups. Usually, sometimes still as many as 15 people. They can't get rid of the corridors, but they can break down the scale of operation of these places, and that's a big start. So one has to look at each individual facility and see whether it's worthwhile doing that.
Okay, Malcolm, I think you were going to say something as well.
Yeah, so I like both of what you were saying, and I want to chip in and say that this is a part of a larger mindset. I mean, if you think of the Royal Society of Canada report, it's a great, it's a sad read, but it's a really interesting read, and it opens up your eyes a lot in terms of the state that we're in. And if you look at it, you would go, of course, COVID has impacted us the way that we're in. Look at how we provide this care. And so, to me, this whole conversation is about a mindset. This is not, if we're going to change things, it's a choice that we're going to make, and it's probably not going to be a cheap choice in some instances that we're going to make. It's going to take some resources to do this, but this whole way of thinking is, yes, we're talking about multiple rooms versus, one person in a room, but it's also part of a bigger picture of, one of the first comments that I've made, and Shauna, both yourself and Rudy have said this, we need to find a way to balance that. We need to provide great medical care to these people because they need it, right? But it's also their home. And that mindset comes with the way the building looks. And my experience is easier to have that mindset when you have a facility with some of those pictures like you were showing, Rudy, in all of this. It's not just the facility. It's the facility plus an approach.
Yeah.
Thank you for that. Next question comes from Ken Clausen. And Shauna, I think this one will be for you. Is the U of M conducting any research related to assessing or improving the indoor air quality in Manitoba's long-term care facilities?
Well,
And anyone can jump in, but Shauna, you can go first if you like.
yeah, I'm currently not involved in any of the research. Ken knows that I do a lot of indoor environmental quality research in workplace environments and schools. We've just completed one of a long-term care facility, but the data's not processed yet. It was part of a larger data set. I think the issue now, of course, for people like me that do field research is we can't get into the buildings to do measurement. So we understand that the COVID is a consequence in terms of indoor air quality. It's going to be a consequence of viral load. So how much virus is present, how much can the system dilute it, an HVAC system dilute it, and then what's the duration of contact? So are people in an environment where they're getting a lot of viral load for a long time, and if the HVAC system's unable to process that and filter it, or you were able to dilute that with openable windows, then you're going to have a problem. And of course, for people living in long-term care, they don't have anywhere to go. So this is where we have people sharing units, multiple people in a room, where we build up viral load. We have people coming in from outside doing personal care for long periods of time. So I don't know, because we don't have the data, but one can easily extrapolate that there's going to be a problem. So we have to think about what we can do to improve indoor air quality, HVAC systems, but also think about how the contact is happening within these units and try to limit that.
Okay, we'll move on to the next question from Sandra Sigurdsson. Can you say more about the cost of building the low-rise household model versus multi-story long corridor nursing station model homes? And Rudy, I'll address that one to you.
Well, I probably mentioned as much as I know about that at this point. But my former firm is involved in these projects in Steinbach and Carmen, and they are building those at almost half the cost of recent long corridor type facilities, like I think there was one built in Morden a few years ago, based on the old system. So part of what happens, especially with low-rise buildings like 1 or 2 story buildings, that is that the building code is interpreted somewhat differently now, and they're not applying the rigid standards of hospitals to these facilities, but rather more of the residential requirements. So, but I'm sure there's more information available, but that's what's happening with those projects that I mentioned.
And I think this will be maybe a bit of a quick answer. I think this one is for you, Shauna. This comes from Rob S. Have any studies been done on any air quality parameters at any of these facilities? So it's similar to Ken's question, but I guess more around studies that have been done at the facilities themselves.
Yeah, I'm not aware of any currently going on in Manitoba. That's not to say they're not going on elsewhere. I would be very surprised if in Ontario and Quebec, those units are not being tested now, but I'm not aware of any studies going on in Manitoba right now.
Okay, next one. Are these new pod designs anticipated to be made available under provincially funded healthcare?
Well, right now in Manitoba, Michelle, all of the PCH sector is well, the vast majority of it. I mean, to be a nursing home, you have to be licensed by the province. So there are different types of nursing homes, for-profit and not-for-profit, but it's all under the rubric of the province. So I would assume, as long as that continues, the answer is yes.
Okay.
Yes, and the projects that I mentioned are being, as far as I understand, being funded by Manitoba Health, or whatever the name of the organization is now that replaced Manitoba Health, and these are for nonprofit, both nonprofit community-based facilities.
Okay, and the next one is a comment. So it's, I would like to see more animals in long-term care facilities. Fish tanks and budgie birds are the most practical. Visiting therapy, dogs are good when allowed to visit long-term care homes. I don't know, Malcolm, if you want to comment on that.
Yeah, no, there's a, what is the home just north of the city? I can't think of the name of it, but it actually has a kind of a quasi-farm where there was goats, I think, there and those types of things. And yeah, it's quite cool, actually.
Well, and there's the Eden alternative model, which is actually started by the same people who started the greenhouse model. Eden alternative has been around for quite a long time, and its approach is basically to incorporate pets, plants, and children into long-term care facilities. And the ones I've seen have been, really quite well done. As an aside, I'll mention the facility in Saskatoon, the Sherbrooke Community Center. They also opened a household model facility in 1999, their first one, 1999, and it was truly the household model. And it was actually that facility that inspired Dr. Bill Thomas to start the greenhouse model. But what I was going to say is that the facility in Saskatoon has a grade 6 classroom embedded right in the facility. So I think that's kind of a neat way of starting to connect different generations.
Okay, next question is around staffing. And so can you comment on research regarding staffing hours per resident per day that are ideal for the small house model?
That is a golden egg question. And so I guess a couple of things. Everyone is trying to get an answer for this. It's a very, very sensitive question. Right now in Manitoba, we give about 3.61 hours of care per resident day. And if you look at that across 10,000 beds and put some salary into there, that's a big number. And if you say, I want to give someone 12 more minutes of care or 10 more minutes of care and start to do calculations as to how much that extra increase is, it's also a big number. There has been work done from down in California, Charlene Carrington, that has tried to look at variation across facilities that have different staff levels and say, where do we start to see changes in quality of care? And, her research says that about 4.1 hours of care per resident day is where we need to get to. But again, I think it's, I'm going to use the word dangerous. I don't mean it but we can't just talk about volume. We also have to talk about doing things differently. And either one of those by themselves is insufficient. We have to talk about both. But yeah, there's very little good research out there to say this is the number that we need to get to.
Well, I think some of the information that I was including in the first part of my presentation is based on research that actually reflects what you're saying. And the greenhouse model, what they claim is that typically there will be 5 hours of staff time per resident per day, and that's based on 2 aides working during the day. Now, these are not the usual aides. They're specially trained to do all those things that need to be done. And of course, the nature of the household model is such that the staff, there are no staff back in the commercial kitchen, because there's no commercial kitchen, so the staff is basically in the unit all the time. But two of those staff each with spending 2 hours with residents per day, and then there's a nurse that comes that usually deals with a couple of households at the same time, adds another hour. So they claim they're providing 5 hours of direct time for each. But I agree. I'm a little reluctant to talk about the amount of time spent, because it's really about quality and not about quantity.
Okay, Malcolm, you were going to add something?
Well, yeah, I mean, I think it's both. The other thing, and again, this is from overseas experience, walking into facilities in Norway and looking around and going, holy, where are all these people coming from? And what they do is they put in more staff at the busiest times of the day, so that the staff level floats around a lot. But they also say, okay, every high school student needs to get credit to complete their high school, and they will have kids that come in and say, well, I'm going to help person X at breakfast time, right? Once they're in the dining room area, and sit with them and eat. And so there's lots and lots of people around at certain times of the day.
Okay, we've got quite a few questions to go, so we'll move on to the next one then. I think we've addressed this a bit, but maybe Shauna, if you have anything to add to what you said earlier, what would you propose as a solution for existing long-term care facilities that are overcrowded and poorly designed without having to displace residents? So do you have anything else that you want to add to your previous comments?
Yeah, bunk beds? No, I mean, clearly, if a facility is overcrowded and overserviced, then obviously it's not sustainable, and we have to build more facilities. You just can't. It's like saying I've got a 3-bedroom house and I've got 11 kids. You can't. If the facility is overpopulated, then obviously that it's not sustainable. I think the issue is that we are going to need to build more facilities. We've got baby boomers coming into their senior years now, and that it's now is our opportunity to really build facilities that can meet those needs, that have a whole different mindset, is what we're trying to get forward here, that the process involves those stakeholders, that we have good design that's not only just functional, but that it's economical and it's got some delight and beauty in it. I think we can have all those three. It's not an either or, it's an and. So we know what to do. That's the frustrating part of it. A lot of I'm sure some of my colleagues are in the audience right now. We know what to do. We just have to get at it, and we have to have the resources to do that. I believe there is money available to build these long-term care homes, but we just have to get going on it. Malcolm may have more to say about that, but I don't know if there's a solution to making an overcrowded place feasible for more, just by moving a few walls and such.
Yeah. We will double the number of 75-plus-year-olds, not to count people as numbers, but that's the math in the years to come, and it's very difficult to not have a conversation about needing more when you look at something like that. The question is, more of what?
More
right?
of what? Yeah. That's the thing.
Right.
We don't need to build
how much
more.
of it should be a nursing home versus something else?
Yeah.
Okay, next question might be a fairly quick one. Does anyone know the percentage of private or single rooms in Manitoba PCHs?
Yes. Let me dig for a second. A very small proportion of the facilities, but they're all very big. And I want to say it's around 18 or 19%, somewhere in there, compared to Ontario, which is awful close to 50.
Wow.
Sorry, what was the question?
On number of beds that are for profit.
No, the question was around that they were single.
Private. Sorry.
Private
I was thinking of for-profit and private.
Yeah, private versus shared.
CBC gave a thing a couple of weeks ago that I think with some math, it's around 16 or 17%. So every 1 in 6 people that goes into a facility about is going into a multiple bedded room, somewhere in there.
So 16% are double or more rooms.
Yeah, and I don't know how they got that calculation, but that's the number I remember coming out from this.
And then there's someone making a comment about it. In at least 2 PCHs in Winnipeg, there are shared rooms, 2 residents in one room, and there are some that also have 4 people in a room too. So
yeah. Now,
Michelle, than in other provinces, it's a lot lower percentage than in other provinces.
Yeah, as long as depending on how the math was done, right? But yes, yeah.
Here's a question. Can you provide your thoughts on how safe visiting facilities could be provided during a pandemic in less time, given most facilities take many months to design?
Yeah, my argument is that there probably is existing space within current facilities that could be hoved off for this purpose. The big concern seems to be that they want a separate entrance for visitors, that they can't come through any part of the facility, and that seems to be the big stop. But I think there could be a way to develop a room that's already in the building for this purpose, and with adequate controls and masks and PPE and such, we could. I would think it would be much easier to renovate an existing room for that purpose and to provide the proper protocols than it would be to build a lot of these CCANs and drive them around. But that's a personal opinion. Clearly, this was an initiative that they felt had worth. So.
Are any of the panelists aware of a post-occupancy evaluation being conducted on any of the recently completed PCHs in Manitoba?
What do you mean post-occupancy?
This, I think, would be something that Shauna would be familiar with doing.
Yeah. This is so any building that has been designed and occupied, and as I said, I'm just in the process of doing a POE of a facility designed for people living with dementia. So we're looking at a pre and post renovation analysis of if any of the strategies used to improve memory support worked or not. So as far as I know, ours is the only study right now, but that's in Manitoba. And I would have to go to my colleagues to find other research. I'm hoping she's on the line. Perkins Eastman just published a white paper looking at the post-occupancy evaluation of 3 long-term care facilities in the U.S. And it's quite a very comprehensive document. It was done pre-COVID, but it has a lot of the points that I just spoke about design strategies for support for both physical wellness, social wellness, social emotional wellness, and intellectual support. Perkins Eastman has a number of white papers. They have an R&D department within their firm, and I'm starting to see a lot more that we have research practitioners in the field that where their firms have R&D departments. So I'm aware of that study. It just got published about a week ago, but I'm not aware of anything going on in Manitoba to look at our existing PCH that have just been constructed.
If that's accessible publicly, maybe you could add that to our list of resources to add.
Yeah, I can add the link. Yeah.
And I'm going to go to the next question then from, I'm probably not going to pronounce this correctly, but Mudra. Is there a set framework to prevent loneliness and the feeling of isolation in long-term care homes?
No, but it's a huge issue. I mean, especially in COVID, right? I mean, that's one of the major things that has affected people. All I can say to that is it is catastrophic, the loneliness piece of all of this. There are a very large number of COVID-related grants that are going into federal agencies right now that are focusing exactly on this. If COVID continues, what can be done to try and mitigate this in some way, shape, or form?
I guess I can add to this because just out of personal experience, my mother-in-law entered an assisted care facility right before COVID hit. She had just moved in. And one of the reasons that we thought she would really benefit from assisted living was the opportunity for more socialization with her peers. There was a Friday night wine and cheese. There was
Mhm.
common dining areas. There was a chance to make friends, and within the facility. But ironically, as soon as COVID hit, the dining room was shut down, and meals were brought to the rooms, and of course visitors from outside the facility were not allowed. So people were really isolated and brought even further into a shell where she had previously been isolated for the fact that she couldn't drive anymore, that she was suffering from a number of chronic illnesses. So these facilities are trying to make up for the fact that they need physical and assistive support for personal care. But there is a ways to provide programming and the co-location of resources for haircutting and music programs and such. But in the time of COVID, the socialization, the isolation that happened even within the facilities was happening. So it really was a formula for intense loneliness. And of course, the staff was just not able to, bring iPads and things around everybody so they could communicate with their loved ones or and such. So I think it's very challenging. I think in a non-COVID time, there's lots of ways to connect with community, to create interactives and collisions, as we call them, in personal care homes, to have meaningful relationships, to have care visitors come in and have meaningful relationships and places to do that, gardening and all the rest. But in the time of COVID, it's been really challenging.
Okay, so the next one comes from another research affiliate of the Center on Aging, Celine Latulippe. I guess is a question, almost suggestion, I guess. Would it be useful to run an interdisciplinary design competition for students to try and renovate older PCH homes to fit the community of small home models? So maybe that's a suggestion for you to take under your advisement, Shauna.
I like it.
Okay, my window here of questions somehow just moved on me. Okay, do any of you know whether Manitoba Health is entertaining a move to smaller, more home-like model to address our future home care needs? I think we've kind of addressed that question. I'll come back. There's some comments that I can come back to.
Michelle, the other thing to say just quickly about this is that I think in fairness, we also need to acknowledge that there has been in the last 5 or 10 years when they have gone about restructuring facilities and looking at building in more homes. At the same time, they have made big efforts to reduce 4-bedded rooms to 3, 3 to 2, 2 to 1. So this is not this. I mean, this pathway is moving towards this single-sided area that we are talking about.
Here's probably a controversial question, but I'll pose it. Should all PCHs be not-for-profit? Does this help us get to the model you are proposing faster and better?
I have to go. So, okay, my response to that is the following. I have looked at lots of data, big administrative data on for-profit versus not-for-profit, and there's a huge body of literature out there. I don't think you can say categorically that a for-profit nursing home doesn't provide as good a care as not-for-profit. I don't think that's an appropriate statement. It is a bit of a mixed bag. For whatever reason, I don't know the answer to this or why this is, but if you look at poor quality of care, sometimes when that is in a for-profit nursing home, it's not subtly worse, it's a fair amount worse. But on average, you can't say that. My experience in more of this is how much the leadership of the director of care, and if they believe in empowering staff and facilitating interprofessional collaboration so that people brainstorm together and work together to provide, creative care solutions to people, that's the thing that really seems to make a difference. I think the for-profit, nonprofit, it's real, but it's not a categorical statement.
I'm going to jump in because I love controversy. I'm also agreeing with Malcolm. That's not the question. There is kind of a carrot and stick a piece for me. We have building regulations that set a minimum standard for design environments. We can set regulatory requirements and standards for licensed environments that are for no matter whatever economic model they're using, they have to meet. We also have in design also awards for people that design exceptional green buildings. Voluntary people actually pay money. They sign up to compete for these awards. And, I think if someone's looking at a facility and they can see that it's been awarded a superior care or superior design award, then that would be appealing, especially if you're trying to attract residents. So I think you can incentivize it. I think the regulations are clearly needing upgrading in some instances. Certainly what I've heard out of Ontario and Quebec, I am astonished that the conditions could be that under a licensed situation. So that would be my, that we could set better regulations and that we could create incentives for better designed environments.
Yeah, excellent comment.
Yeah. I'll just add to that. The Dr. Sinha, who is based in Toronto, and he's with I'm trying to remember now the name of the organization. It's something like the Center for Aging, which is not your organization, but he's very knowledgeable, and I've been very impressed with him, and have communicated with him about this and other things. And his opinion is that ownership is not an issue at all. The problems are much different, and based on, well, there's a lot of reasons why long-term care is failing in Canada, and he can pinpoint them. But on the other hand, most of the deaths in Ontario, particularly in Ontario, were in private for-profit homes. Not all of them, but most of them. And so I think it really boils down to enforcement. There should be people. The government should have. The government itself should not be in the business of owning long-term care, but they should be in the business of enforcing those standards that you talked about, Shauna.
Okay, now a completely different question. Is there a role for robots in long-term care?
Ooh.
And I'm thinking here we could be talking about robots for socializing, robots for providing care, robots for reducing isolation. We've got a variety of different robots out there.
I have to pitch the work that's going on in the health sciences group right now to build the Smart Suite, where they're going to be looking at innovative robots of sorts, but all sorts of assistive technologies for helping people live longer independently, either in their own homes or in remote communities. So the obvious one is the ability to develop healthcare and support in remote communities via e-health and using quick ways to check your blood sugar and quick ways to get feedback from a doctor. And of course, this is we see this now in the time of COVID when we can't go to visit our doctor physically. These things are really being pushed forward faster. So these kinds of technologies are coming around the bend, and I think they will allow people to live longer in their own homes, because that kind of feedback and quick delivery of medical care might be beyond personal care, but there is definitely some work being done to try to allow for the delivery of healthcare, at least in home. And we're going to be looking at designing kitchens that can grow with you or age with you. So that is the Smart Suite at the Health Sciences Center is going to be the center for some of that innovation.
I recently attended a webinar on this very topic, use of technology in care and other facilities for older adults. And there was a lot of different ideas about using robots. I think the bottom line was that they should be used for the menial tasks that you don't necessarily want your staff to have to do. One was actually delivering meals, but the more important ones were like cleaning, disinfecting rooms. Like a lot of people apparently now already have vacuum cleaners in their homes that are robots. Well, that can be taken much further, and you can do all kinds of really important disinfecting and so on. So the point was to use robots for those kinds of tasks, but not for social engagement with residents.
No.
Okay, and well, Malcolm, if you have a quick point
Yeah,
here.
no, Rudy just said it. I mean, as long as it helps to support personalized care, not replace it.
Yeah.
That's the.
Yes.
This is more a question related to perhaps something that you might be able to answer around transitions in care. Are hospitals discharging many patients into PCH to receive end-of-life care? No, as hospitals are discharging many patients into PCH to receive end-of-life care, is the household model designed to meet the needs of residents at the end of life?
Well, I can't speak about the difference. I can talk about generically, right, this model of care. I'm not sure how much of this is going to be. I don't have a yes/no answer to this. I mean, the first thing is end of life is a very complex topic, right? When does end of life start? Is it the active dying process? Is it someone in their last month of life? There's a lot of literature out there that talks about the challenges between nursing homes and emergency departments, for example, and the transfers that go on back and forth, particularly at end of life. I have a PhD student that's focusing on this. And, you know, a lot of it boils down to how do we know when transition should happen versus shouldn't happen, and who makes that decision? Lots of times someone will get transferred from a nursing home to an ER, and what the ER thinks is not an emergency, the nursing home does think is an emergency. And sometimes the communication flow back and forth is not the best in all of this. CHR, our federal funding agency, considers this such a challenge where they've actually said, we do a pretty good job when we actually provide care to someone once we get them in the bed. Where we do not do a good job is people don't use one aspect of the healthcare system. They move across, they transition across all aspects of the healthcare system. And that transition needs a huge improvement. And they have dedicated funding streams for this type of thing exactly.
If I can comment, to me, an end of life situation like that is about palliative care. And that person should be put into some kind of palliative care, either a facility or at least some kind of context. I think the problem is that many people think that when you go into a certain type of long-term care facility, and I think in Winnipeg, probably the Riverview one is considered this way, that they're going there to die. And I don't think anybody should be going into a long-term care facility to die. I spoke with someone recently who works in one here in Nanaimo, and he calls it was it's a personal care home. He calls it a palliative hospital, and I said, "Why do you call it that?" He said, "Well, people come here to die." And I thought to myself, "Well, that's pretty sad that's the attitude of to all your residents, that they're just coming here to die." So I think there's an attitudinal issue there.
Okay, well, we're pretty much at the end. There's a few comments that people have made that I think I will read out just to add to the conversation for tonight. So there's one around the design of the visiting units. So the specifications for the visiting facilities and design of each PCH unit, I believe were prepared by registered architects specializing in healthcare. And there was another one around also the visiting, saying that the Manitoba government is renovating every PCH to provide visiting facilities, including dozens of repurposed resident rooms and rec rooms, as per Shauna's suggestion. So there are some PCHs, I don't think it's all of them necessarily, but they are redesigning some of their space to provide indoor visiting inside the home rather than having the shelters on the outside. Someone wanted to know about the resources, and the resources will be on, I believe, the same website, and I will get to that address in a second. And then there's a comment that I think is along the lines of what Shauna said. At one point in time, design is not the challenge. Lack of government funding for 20 years is the underlying problem. Design of proper facilities have been known for decades. So perhaps that is a place to end the conversation. That we have a lot of knowledge. You've shared a lot of that knowledge with us tonight. And hopefully, as this conversation continues in the country, that we're going to move forward with providing buildings that are good homes for people where they can live in dignity with good health and good quality of life. As the Decade of Healthy Aging is trying to have us all move in that direction. So I'd like to thank everyone who's attended this evening's event, as of course all of the panelists for sharing your knowledge and entering into the discussion. As I said, the information, the resources will be available, and the website is umanitoba.ca/Café Scientifique. And if you're associated with the Center on Aging, we will also put that link into our updates, and we'll probably put it on social media as well. And the recording will be available on that same Café Scientifique website that I mentioned very soon. And there is an upcoming another Café Scientifique on a very different topic. So it's on October 26th at 7 p.m. again. And the topic is parenting during the pandemic.
I could be on that panel too.
Thank you very much, everyone, again, for your participation, and have a good night and take care. Bye-bye.
Thank you. Bye-bye.
All right.